are reproductive factors controlling spermatogenesis. These will be our next 40-45 minutes. We shall be covering up this area. Spermatogenesis, formation of spermatozoa that happens inside the seminiferous tubule. Then we have this retitestis, which was the network coming out of the seminiferous tubule. Then we have the ductus efferens, efferent duct, which ultimately drains into this epididymis, which is a highly tortuous and thick structure present over or alongside the testis. Now this has one head, after that it has body, tail, and that ultimately goes into ductus deferens, which becomes the vas deferens and goes an enormous path back to the prostate, connected with the seminal vesicle over there, connected with the bulbourethral gland over there, ultimately draining into the ejaculatory duct, which opens up in the urethra. That's the whole path if we look at the macro system. And then what we did, so this was the cross section of seminiferous tubule, where we had, you can see there are spermatocytes or various germ cell at various area of life, various phase of life. So usually what happens, the more primordial, they are more closer to the tunica albuginea, and that way a column is developed over there. And apart from that, we have large cell, colloid containing cell. In between these two, these are the Sertoli cell. And outside we had Leydig cell, which was in the interstitial space. So today's discussion will be on the basis of this Sertoli cell and Leydig cell. That is the most important thing. Sertoli cell has a number of functions and it works under the action of FSH. Sertoli cell helps in chemical way, Sertoli cell helps in physical way. Physical way means formation of the blood testis barrier. In that way it protects, in that way it maintains high testosterone content. It secretes certain substances which increases the concentration of testosterone. It secretes certain substances which improves the function of Wolffian glands and which regresses the Mullerian duct system. Kind of that. So that is the way males are differentiated into males and female reproductive system structures are actually annihilated in that way in the male body. That's the basic thing embryologically. Apart from Sertoli cell, what we have the cells of Leydig. Leydig cells are not inside, it is in the interstitial area. And in the Leydig cell, they work under the action of LH, luteinizing hormone, and they secrete testosterone. And this testosterone comes into the seminiferous tubule by local transport. We call it paracrine effect. So testosterone jeta dhukche Leydig theke just inside, that is by paracrine effect. And we need to remember two important things. Last day also I mentioned that definitely Sertoli cells, by the presence of tight junction, they form the blood testis barrier. But there is one particular structure or chemical which can cross through this barrier, that is steroid. Testosterone is also a steroid, so it can come in. Okay, and inside seminiferous tubule, with the help of secretion from Sertoli cell, we have more maturity of it, we have more concentration of it, and it has its own biochemical pathway. That is the whole macro picture. Now coming further, so what we have, if we look at this one, we have this seminiferous tubule, which is the kitchen for spermatozoa. Seminiferous tubule, where from the raw material spermatozoa or spermatogenesis is happening inside. After that, what is there? So basically this is the macro structure, and inside seminiferous tubule, this spermatozoa, they are formed, then they are going to the epididymis and all things are happening like that. Now important is, whenever this sperm, this is single sperm, it crosses the whole male genital tract, then it goes into female genital tract and it crosses that. Basically at that time we need multiple support, and this support is coming from the accessory sexual organs. So regarding that we will be writing a few things and then I shall be explaining what exactly they are doing. So in accessory sexual organ, first you will be writing like that. Name of the organ, substance, function. Name of the organ, substance, function. তাহলে কি দাঁড়াচ্ছে যে সেমিনাল ফ্লুইড যেটা তাতে only spermatozoa থাকলে nothing will happen. Fertilization possible না, because spermatozoa first of all in an acidic environment it will be very difficult for them to survive. So in female genital tract in acidic environment it will not survive unless it is getting some support from this. Second, if there is not enough lubrication again, they can't survive and they can't propagate to the end. Third, they need certain nutrients all through so that they can control the acrosomal reaction. For that also they require certain supports. So we are starting, first is accessory sexual organs, seminal vesicle. Seminal vesicle. Left you will be writing the name, middle you will be writing what substances they are secreting, and on the right side in one single sentence what is its function. So first is seminal vesicle, fructose. Seminal vesicle secretes fructose. Underline this is a very important MCQ. Seminal vesicle secretes fructose. What fructose does? Remember one thing, fructose helps in energy supply via GLUT5 transporter. Fructose helps in energy supply via GLUT5 transporter. So glucose transporter 5, that is actually a fructose transporter. If you remember, I mentioned this maybe 6 months back also. এই যে GLUT5 টা হচ্ছে এটা খুব ইম্পর্টেন্ট, আন্ডারলাইন করো, এটা এমসিকিউ, এই জায়গাগুলো থেকে এমসিকিউ ভীষণ তৈরি হয়। সেকেন্ড কামিং prostaglandins. সেমিনাল ভেসিকল থেকেই আসছে কিন্তু মিডল স্ট্রাকচারে, মিডল কলামে ইউ নিড টু রাইট the prostaglandin. This is the second thing that is coming. So prostaglandin, what are the functions of prostaglandin? Kiki function, what do you know? Ki kore prostaglandin? So definitely the vascular structure and endothelial. So prostaglandin ekhane lekho various endothelial pathways. And if we just go back for some part of general physiology, prostaglandin and different parts, they are coming from icosanoids actually, and these are happening via the arachidonic acid pathway, if you remember. So they have multiple things. They can cause, suppose, dilatation of certain smooth muscle structure. They can cause vasoconstriction depending on what type of prostaglandin they are. They can cause vasodilation. They can lead to generation of EDRF, endothelial derived relaxing factor, most common of which is nitric oxide. So you can just take a shot, if you want to write, you can just write, but the main thing is various endothelial reactions are done by the prostaglandin. And the third is fibrinogen. That is also coming from this seminal vesicle. Now this has a very peculiar action. Presence of fibrinogen in seminal fluid, we have both clotting factors, prothrombotic substances and thrombolytic substances. No need to write right now, just listen, I will give notes. So prothrombotic substances and thrombolytic substances both are there. That's why seminal fluid initially it clots, later it gets degraded or later it liquefies. And what's the natural benefit of it? Natural benefit, if it is clotted initially, so sperms can anchor in the female genital tract. So during the coital movement, sperm can still anchor or stay over there during the movements. And after some time, if it is still remain clotted, so there will be no motility. So nature has provided this unique advantage. So after some time that is liquefied and the motility is restored by the sperm and they can start forward movement. And this forward movement, if you remember from the last day, we had central fibril surrounded by a huge number of mitochondria. Caspar protein I have discussed, that was present in which was a calcium containing cation channel and which opens up under action of second messenger like CAM, adenylyl cyclase. All this we have discussed, and on the basis of that it can start moving. So fibrinogen, and the importance of fibrinogen on the right side you can write initial clotting or solidification of seminal fluid inside female genitalia. Initial clotting or solidification of seminal fluid in female genitalia. That is all about the seminal vesicles. Now next we are coming to the next sex organ, accessory sex organ, that is prostate. Very important. Prostate, be ready for a short note. And যদি প্রস্টেটের শর্ট নোট ফিজিওলজিতে আসে তাহলে একটু অ্যানাটমিও কিন্তু বলতে হবে, ল্যাপ্টোমিক্স ওগুলো কিন্তু এগুলো these are actually interdisciplinary. So if prostate function of prostate might come or prostate short note itself might come. প্রত্যেকটাতেই আসতে পারে, even can come in anatomy. Again interdisciplinary writing should be there. Okay, so here we are pointing towards the prostate substances. First substance that prostate secretes alkaline fluid. Alkaline fluid, because it is rich in bicarbonate. So bicarbonate rich alkaline fluid. What is the function of that? On the rightest column, you just write. What is the function of this alkaline fluid? It neutralizes acidity in female genital tract. It neutralizes acidity in, or it neutralizes low pH in female genital tract. What is the benefit? Remember, sperm motility increases in alkaline fluid. Sperm motility increases in alkaline medium. So, alkaline fluid, alkaline support from prostate actually increases the sperm motility. Second comes clotting factors. Clotting factors, that is also coming from the prostate. So again, initial coagulation, initial phase of coagulation or solidification, same as we have just mentioned. Third is important. Third is fibrinolysin. Fibrinolysin. Now that is important. Fibrinolysin, what it does? It causes the second phase liquefaction of seminal fluid. And fibrinolysin, this is the spelling. Fibrinolysis, what it does? Second phase of liquefaction that happens inside the female genital tract. So if the seminal fluid in the second phase becomes liquid, motility will increase. Then just now এটা যেটা বললাম সেটা এখান থেকে ব্যাপারটা হচ্ছে লাস্ট জিঙ্ক। জিঙ্কের কাজটা কি হচ্ছে? জিঙ্ক ইজ আ ট্রেস এলিমেন্ট। কি করছে? মাল্টিপল nuclear and extranuclear reactions and metabolic pathways. Zinc very important in sperm maturity and sperm motility. So you can write various chemical reaction involved in sperm maturity and sperm motility. Various chemical function or reaction involved in sperm motility and sperm maturity. এই জন্য অনেক সময় what is a common practice in case of infertility, we usually start with this kind of substances, multivitamin containing zinc, containing certain antioxidant. That's a very common practice. Occasionally we do have proof in support of them, occasionally we may not have proof, but still that's a very common practice to give support, nutritional support to the environment. And last is bulbourethral gland. That's the third accessory sex organ. So third accessory sex organ নাম হচ্ছে bulbourethral gland. তো bulbourethral gland এর আরেকটা নাম হচ্ছে Cowper's gland. Cowper's gland. কি করছে bulbourethral gland? It secretes mucus. Lubrication. So it function হচ্ছে lubrication. So এটা একটা short note ছিল that we have just now covered. Accessory sex organs আসতে পারে পরীক্ষাতে. You need to draw the picture. পিকচারটা ওইখান থেকে আসবে আগের দিন হয়েছে যেটা. So that's the picture. Initial যে পিকচার ছিল এটা একটা আঁকতে হবে. তারপরে you need to move into এর মধ্যে seminal vesicle will come into picture, prostate will come into picture, and bulbourethral gland will come into picture. That you need to do. Okay. Next, we are moving into some factors which are controlling the spermatogenesis. This is a long question. Factors controlling spermatogenesis. Multiple factors. There are physical factors, there are structural factors, there are chemical factors. যারা spermatogenesis-টাকে control করছে. So first we are starting with the physical factors. Factors controlling spermatogenesis. First is the physical factors. প্রথম physical factor যেটা হবে, that is blood testis barrier. Blood testis barrier. কিভাবে হচ্ছে? See, we all know that spermatogenesis starts like if we look at this picture. So spermatogenesis happens inside the seminiferous tubule where we have the Sertoli cell and we have sheets or columns of germ cell at various levels of maturity. Now these germ cells are extremely delicate. If any antigenic response happens, if any toxic substances reaches them, or if favorable osmolar gradient is lost, in that case either the germ cell will be destroyed or lose their propagatory or differentiating ability, or even after that another problem, if osmolar gradient is lost, spermatozoa will be formed but they will not move towards the epididymis. Again, it is of no use. So basically blood testis barrier that helps maintaining all these three things. So first of all, what it does, blood testis barrier formed by tight junction between Sertoli cells. Tight junction between adjacent Sertoli cells. One of it, just ছোট ছোট করে লিখে রাখবে, prevents antigenic substance to enter into testicular environment from blood. First one, prevents antigenic substances to enter testicular environment from blood. Number one. Number two, maintains the adequate concentration of testosterone inside seminiferous environment. Maintains the adequate testosterone-টাকে ক্যাপসে টি দিয়ে লিখতে থাকো, it will be quicker. তাড়াতাড়ি লিখতে পারো. Maintains the, যখন আমরা ইস্ট্রোজেনে আসবো একটু পরেই, তখন ই ক্যাপসে ই দিয়ে লিখো, it will be quicker. So maintains the adequate concentration of testosterone inside the seminiferous environment, tubular environment. Number three, provides or maintains specific electrolyte concentration, maintains specific electrolyte concentration to control osmolality inside the seminiferous, inside and around the seminiferous tubules. So maintain specific electrolyte concentration. কি করে করছে সেটা একটু পরে আসছি. To provide osmolarity or to control osmolarity inside and around the seminiferous tubule. এই তিনখানা জিনিস দ্বারা হচ্ছে blood testis barrier. Done everybody? So we are moving to next topic, that is হচ্ছে position of testis or extra abdominal position of testis. Extra abdominal position of testis. সেটা কি? As we know, testis is present outside body. Testis is present outside body. তাতে কয়েকটা assumption হচ্ছে number 1, scrotal temperature is 4 degree centigrade, 3 to 4 degree centigrade below intra-abdominal temperature. Spermatogenesis requires, or spermatogenesis, rate of spermatogenesis is the base at 32 degree to 33 degree centigrade. এইটা টেম্পারেচার হওয়া উচিত spermatogenesis এর জন্য. If the testis is inside the abdominal cavity, it will not happen. সেখানে কত আমাদের ইনসাইড অ্যাবডোমিনাল ক্যাভিটি 37, কোর টেম্পারেচারটা তো 37 এর কাছাকাছি হবে না, অনেক কমে যাবে. and that is the reason again টাইট ফিটিং ইনার গার্মেন্টস বা যারা খুব একটা হিটেড এনভায়রনমেন্টে কাজ করে তাদের ক্ষেত্রে ইনফার্টিলিটি দেখা যায়. লেবার্স হু আর ইন ফ্রন্ট অফ সাপোজ ফায়ার ফর আ লং টাইম তাদের ক্ষেত্রে ইনফার্টিলিটি দেখা যায় বিকজ অফ দিস. সো স্পারমেটোজেনেসিস তার জন্য অপটিমাল টেম্পারেচার ইজ 32 ডিগ্রি to 33 degree centigrade. Clear? So that is one. Second, premasteric muscle contraction. Premasteric muscle contraction. কি হচ্ছে? বুঝতে পারলাম না কি? রিপিট কোন জায়গা থেকে? premasteric muscle contraction আরো আগে মেইন ব্যাপারটা বোঝো. যদি spermatogenesis হতে হয় 32 ডিগ্রি সেন্টিগ্রেড is the optimal temperature. I need to provide the seminiferous tubules an optimal temperature. Now if this, why all these questions are coming? Because in females gonads are inside the abdominal cavity. In males, why this difference? Difference is just for the sake of keeping alive and keeping functional the delicate germ cell. That is the main thing. So for that I need to provide a lesser temperature, that is 32, or cooler temperature 32 degrees, and that is only possible when this is outside, testes are outside the abdominal cavity. So that is done by this, number 1. Second, কি বলছিলাম আমি তো ভুলে গেলাম পরের লাইনে. premasteric muscle, yes, premasteric muscle এর আগে আরেকটা জিনিস লিখে নাও, descent of testis. এটা বোধহয় তোমরা আগে অ্যানাটমিতে পড়েছো, পড়েই নিয়েছো, এখানে আমাদের বিশেষ কিছু বলার নেই. Only thing is descent of testis is testosterone or androgen derived process. এটা একটা পয়েন্ট মাথায় রাখতে হবে. Descent of testis is an androgen derived process. And সেটা কি হচ্ছে যে embryological life এ দেখা যাচ্ছে the testis is inside the cavity but it descends down. Yes, gubernaculum যেটা ছিল it descends down. এটা নমিতে পড়েছে আমাদের এখানে একটা যেটা বলার cryptorchidism. What is that? Cryptorchidism. So যেখানে there is a failure to descend. So that's an embryological defect or congenital anomaly. Jodi cryptorchidism থাকে, in that case these testes are non-functional as well. Okay, these testes are non-functional. একটা syndrome আছে, I don't know whether you know or not, most likely you are knowing, androgen insensitivity syndrome. Part of this androgen insensitivity শুনে লিখতে পারবে তো এগুলোর মধ্যে? তো I need not go and write. Androgen insensitivity syndrome or testicular feminization syndrome, the same thing. I am explaining the thing. Androgen insensitivity syndrome or same phenomena, it is known as testicular feminization syndrome. এটা কেউ জানো না? এই শব্দগুলোকে if you dissect the words that I have said, তাহলে can you reach to some idea? এই কথা, এই শব্দগুলোকে ভেঙে কি বুঝতে পারছো? During development, yes, it is during development something is okay. Thing is, এদের ক্ষেত্রে হচ্ছে যে huge area of spermatogenesis, huge area of development of secondary sexual characteristics, huge area of development of accessory glands and their function, and also descent of testes. All of these are testosterone dependent. Clear? এইটা প্রত্যেকের clear? Now testosterone doesn't work by itself. It needs some receptor to work. These receptors are present on all these organs that I have just mentioned, whoever is being developed. Now, if by some genetic defect, either the receptors are not present all receptors are non-functional. Even after testosterone being present in the fetus, male characteristics will not be developed. তাহলে কি হচ্ছে, this fetus তাদের testosterone level is okay, even more, কারণ কি কাজ যদি না করে ফিডব্যাকে টেস্টোস্টেরন আরো বেড়ে যাবে। So even more in all hormonal areas, you know, if receptor defect is present, তাহলে এটা বেড়ে যায়। যেমন I think you have already gone through diabetes, insulin resistance, এটা insulin receptor defect হয়, peripheral resistance থাকে, এদের fasting insulin goes high, not low. Type 2 diabetes এর যাদের obesity রয়েছে, যাদের metabolic syndrome রয়েছে, they have a higher fasting level of insulin. So basically যেখানেই receptor defect, you will be seeing the previous hormone level is high, because that is body's trials to improve this situation. So androgen insensitivity system, these fetus, they have androgen, but they don't have functional receptor for the androgen. তাহলে কি দাঁড়াচ্ছে, ফিটাসটা যখন গ্রো করছে, at that time no body is not getting signal from testosterone. So body is not getting signal that it has to be converted in a male. এই জিনিসটা দাঁড়াচ্ছে। So body কি করে বাড়ছে, right from the fetal period, body মাথায় রাখবে, ফিমেল কিন্তু ডি নোভো, যদি সিগন্যাল না আসে তাহলে এমব্রায়ো ফিমেলে কনভার্ট হবে। ডু ইউ হ্যাভ দিস আইডিয়া? যদি সিগন্যাল আসে only then it will move into male. So যদি কোনো সিগন্যাল না থাকে জেন্ডার ডিসক্রিমিনেশনের, তাহলে ফিমেল ফার্স্টে তৈরি হবে। ক্লিয়ার? এইবারে যে জিনিসটা দাঁড়াচ্ছে, in such scenario, since no signal is coming from androgens are there, androgen receptors are not working, তাহলে this fetus, they will develop, they will phenotypically become females. But phenotypically, this is very interesting, phenotypically they will become female. So বাচ্চাটা যখন জন্মাচ্ছে, everybody will say that this is a female baby, because external genitalia is of female, because it didn't get any signal from testosterone. But genotypically they are male. The problem is that কারণ কি testis ছিল, but testosterone ছিল না। So genotypical male, তাদের যদি if they have testes, but if they don't have any signal from testosterone, there will be no descent of testes. So these people will have intra-abdominal testes. Hello? এইবারে how the story will unfold. Problem will happen in more vast majority, because when baby is born, nobody goes and check the ultrasound of the baby's abdomen. And we check the baby's abdomen ultrasound, we could have found that there is some testis-like structure inside the thing, inside the abdomen, and we will go for some certain more examination. Usually what happens, these babies are born, externally they look like female, they are treated like female, they are being brought up like female. এবং they have sexual characteristics of female, secondary sexual characteristics of female too, because testosterone is not working. Phenotypically female হয়ে চলছে। So all secondary characteristics of female সেগুলো এদের মধ্যে থাকবে, but strangely primary characteristics of female টা থাকবে না। তো এদের ক্ষেত্রে কি হবে, their gonads will be testes which will be non functional, basically secondary গুলো চলছে। এরা ধরা কি করে পড়ে, how they are diagnosed? So usually যেটা হয়, this testosterone insensitivity or androgen insensitivity, usually they become very good looking female, because এদের পুরোটাই ফিমেল হরমোন গুলো কাজ করছে। After marriage or maybe in puberty, they don't get menstruation, then they come with primary amenorrhea. এমনও অনেক সময় হয় যে some of them are even having blind vagina, that means ওটা up to uterus জিনিসটা যাচ্ছে না, but initially first part of the vagina is still present. Various এটা হতে পারে, কতটা তার রেসপন্সিবিলিটি তার উপর ডিপেন্ড করছে about the thing. So usually যেটা হয় যে female patient comes up with primary amenorrhea. Primary amenorrhea means they never had menstruation. Secondary amenorrhea means menstruation was started, but now it is stopped due to any cause. Commonest cause of secondary menstruation is pregnancy. Secondary amenorrhea is pregnancy. বুঝতে পারলে তাহলে what is amenorrhea? তো এদের ক্ষেত্রে এই জিনিসটা আসে, and then all the workups are done, তারপরে abdominal USG করে that we can find that they have testes, that is intra-abdominal testes. সেটা spermatogenesis করতেই পারছে না most of the time, and the pathetic thing regarding this, remember এই যে জার্ম সেল যেগুলো রয়েছে, জার্ম সেল আর ভেরি ডেলিকেট স্ট্রাকচার and any time they can move away from the normal process and easily they can be channelized into neoplastic particles. So এদের ক্ষেত্রে intra-abdominal testis থাকে which is non-functional, and in most of the cases these are pre-malignant. Very sadly they will have this testis will be turning into some kind of malignancy later in life. Life expectancy is short term. ঠিক আছে, সোজা প্রশ্ন হলে ক্লাইনিফেল্টার্স, টার্নার্স আর আমাদের ডাউনস। কঠিন প্রশ্ন হলে এটা কি পয়েন্ট বলেছি জোরে প্রিমাস্টারিক মাসল ডিড উই প্রিমাস্টারিক মাসল কমপ্লিট করি না। প্রিমাস্টারিক মাসলে কি হচ্ছে, ডিউরিং কোল্ড ওয়েদার প্রিমাস্টারিক মাসল কন্ট্রাক্টস এন্ড টেস্টিস গোজ হায়ার, অর মানে কি হচ্ছে স্ক্রোটাল ওয়ালটা কন্ট্রাক্ট করছে, টেস্টিস গোজ হায়ার এন্ড ক্লোজার টু দি ইন্ট্রা অ্যাবডোমিনাল ক্যাভিটি। সো তাহলে কি হচ্ছে, যত ইন্ট্রা অ্যাবডোমিনাল ক্যাভিটি দ্য ক্লোজার ইট গেটস the warmer it gets, and during warm weather premasteric muscle relaxes, so scrotal sac descends down, testis moves further away from the intra-abdominal cavity, and you can write I think এটা আমার লেখানোর কিছু নেই, and that is happening. Okay, so this is the thing. এরপরে যেটা আসছে ফিজিক্যালের মধ্যে কাউন্টার কারেন্ট মেকানিজম। কাউন্টার কারেন্ট মেকানিজম, কাউন্টার কারেন্ট মেকানিজম ঠিক যেমন inside the nephron, not inside the nephron, inside the kidney actually, surrounding the nephron, we do have a counter current mechanism. Similarly, around the seminiferous tubules, around the testes, in this environment, we also have a counter current mechanism. This counter current mechanism কিভাবে কাজ করছে? Here, in an U shape or in opposite direction, thin spermatic arteries and veins are present. So, spermatic artery or vein গুলো in an opposite direction present থাকছে। So, movement of fluid in spermatic artery and vein are in opposite direction. এই জিনিসটা হলেই what happens, এই জিনিসটা একটা কুলেন্ট। যখনই আমাদের এরকম একটা কিছু থাকবে, so in every area they will lose some of the heat basically. So কি হচ্ছে, warm blood transfer from spermatic artery to spermatic vein. Warm blood transfer from spermatic, blood transfers from spermatic artery to spermatic vein, and testosterone comes from spermatic vein to spermatic artery in an opposite direction. Testosterone comes from spermatic vein to spermatic artery in an opposite direction. In this process, there is gradual loss of heat. There is gradual loss of heat due to counter current mechanism, which helps in providing a cooler temperature in and around seminiferous tubule. Seminiferous tubule ke is dot P kore dao, which helps in providing a cooler temperature in and around seminiferous tubule. So এটা মোটামুটি যেটা গেল আমাদের physical factors. Now we are coming to biochemical factors or biological factors. Physical factors গেল, biological factors. এইখানে একটা জিনিস আছে, এর মধ্যেই I will be doing the Sertoli cell. এর মধ্যেই will be doing the Sertoli cell. So biological factor এ first হচ্ছে main factor যেটা থাকছে biological factor এর, that is Sertoli cell. And Sertoli cell এর উপরে কে কাজ করে? FSH. First thing. Biological factor এ first is coming the Sertoli cell, and Sertoli cell এর উপরে কাজ করছে হচ্ছে FSH. So what are the functions of Sertoli cell? Number 1, আসছি glycogen rich content. Glycogen rich content. Sertoli cell এর মধ্যে যে colloid rich content, glycogen rich content আছে, that provides continuous energy and nutrients to the germ cell, to the development. Germ cell means huge level of propagation হচ্ছে, they require huge amount of energy. even more than what we require, because এগুলো একটা থেকে দুটো থেকে চারটে 64, প্রত্যেকটা থেকে 64 সেল তৈরি করতে হবে. They need a huge amount of nutrient and energy. So I need continuous supply of energy, that is from the glycogen rich Sertoli cell. Second thing, what Sertoli cell helps in biological factors, Sertoli cell কিসে হেল্প করছে? ABP মানে আমরা যেটা ভাবছি সেটা না, androgen binding protein. Androgen binding protein কি করে? So basically androgen binding protein catches testosterone. So it binds with testosterone and it concentrates testosterone inside the seminiferous tube. So androgen binding protein টা testosterone concentration টাকে বাড়াচ্ছে inside the seminiferous tubule. কতটা concentration বাড়ে? How much? Is seen up to 100 to 120 times testosterone concentration happens inside the seminiferous tubules under the function of androgen binding protein. And you know, testosterone is required for spermatogenesis, so definitely it is helping in spermatogenesis. এখানে দ্বিতীয় প্রশ্নই নেই. 3 নম্বর, এটা একটু কাউন্টার মেকানিজমে কাজ করে. It also secretes something called inhibin. Inhibin টা actually maintains this, inhibin টা এটাকে ব্লক করে. Inhibin এটা জাস্ট একটা লাইন লিখে রাখা. So definitely too much হলেও তো মুশকিল. We need some regulatory point and inhibin does that. Inhibin has its role in puberty also. যে কখন FSH LH right from the beginning we do have, but কেন 12 years 14 years অবধি সেটা ওয়েট করছে to create, or maybe 10 years whatever puberty আসার জন্য. Inhibin has a very, and there are some mysterious chemicals, other mysterious chemicals also যেগুলো yet to be understood, যারা puberty switch not completely understood so far. So inhibin is one molecule puberty ক্ষেত্রে কাজ করছে, and day to day FSH regulation, feedback mechanism এ regulation ও inhibin is very much important. এটা গেল 2 নম্বর. What else Sertoli cell does? Sertoli cell secretes MIF, Mullerian inhibitory factor. লিখে নাও, কতটা লিখতে হবে না I guess. Mullerian MULLLERIN, এর উপরে আবার ডবল ডট আছে. হ্যাঁ, একটু মোস্ট, হ্যাঁ ওই ইউরোপিয়ান জায়গা থেকে আসছে আর কি, ইউরোপিয়ান ডিসেন্ট থেকে আসছে. সো Mullerian inhibitory factor এটা কি করছে? রিগ্রেসেস দ্য Mullerian duct system. তাহলে কি হচ্ছে যে এটা নেগেটিভ এফেক্ট দিচ্ছে জিনকে, ইট ইজ altering to the gene that don't become a female. That's the thing. Mullerian inhibitory factor না যদি যায় তাহলে body will move into the female development path. That's the thing. Okay. Second, HY antigen. HY antigen, differentiation and development of testes and testicular structure. HY antigen Sertoli cell থেকে আসছে. Differentiation and development of testes and testicular structure. Development. শুধু development মানে কি? Development means mitosis and hypertrophy. Nutrition ঢুকছে. Differentiation মানে কিন্তু meiosis হচ্ছে. এবং next line of cells it is being converted. These things are different. What else? Sertoli cell has its own inherent secretion. এত কিছুর বাদে, হ্যাঁ, testosterone etc. যা কিছু হলো, it has its own inherent secretion, and that inherent secretion of Sertoli cell is rich in potassium and bicarbonate. So Sertoli cell has its own secretion rich in potassium and bicarbonate. এটা কি করছে? This maintains the osmolality inside the seminiferous, inside and around the seminiferous tubule. This maintains the osmolarity inside the seminiferous tubule. তাতে benefit কি? না, not only that, the best benefit হচ্ছে এইটাই একটা osmolar gradient দিচ্ছে, so testosterone will move from Leydig to Sertoli to the lumen. spermatozoa will move from germ cell to the lumen. So favorable gradient for testosterone transport and spermatozoa transport. Otherwise উল্টো দিকে চলে যেত বা accumulate করে যেত. Understood? তাহলে this potassium and bicarb is giving a favorable gradient for the transport of testosterone and transport of spermatozoa. And blood test is barrier সেটাও সার্টোলি সেলই করে, but that doesn't come under the biochemical, that comes under the physical. We have already discussed that. Blood test is barrier টাও তো সার্টোলি সেলই করছে. So this is all about this one. Now সার্টোলির পার্টটা হলো, so সার্টোলি সেল, be ready for short note. কোথায় থাকে পিকচার দেওয়া রয়েছে, if you can draw the picture, then all the functions of the Sertoli cell. লিখে শেষ করা যাবে না, এবং এটা if you can, whatever I have mentioned with the picture, if you can do, there's high chance you will get 90% and above in this. মানে 4.5 দিয়েই দিতে হবে, তারপরে depends out of 5. Now we are moving to next thing, যেটা spermatogenesis আরেকজন যে কাজ করে, who is the Leydig cell. So Leydig cell এ কোথায় থাকছে? Leydig cell is outside the seminiferous tubule in the interstitial space. ওই যে ওখানে রয়েছে in the interstitial space. Leydig cell কি করছে? Leydig cell is under the action of LH. So luteinizing hormone এ হচ্ছে Leydig cell, তার আন্ডারে কাজ করছে. Leydig cell under the action of LH, and Leydig cell creates testosterone, and this testosterone is then moves into seminiferous tubule or moves into the in closer proximity of germ cells, seminiferous tubules or closer proximity of germ cells. কিভাবে হচ্ছে? By a paracrine effect. একটা সেল থেকে adjacent cell এ যখন hormonal transfer is happening, we call it paracrine effect. That is happening over there. So remember one thing, testosterone can cross through blood testis barrier because it is a steroid. I've mentioned that one molecule which can cross it, that's a steroid. It is lipid soluble, that's why it can cross the blood testis barrier. So এটা তৈরি হচ্ছে Leydig cell, then it is getting out of the Leydig cell, and via paracrine effect it is affecting on the local structure by crossing the blood testis barrier. And তারপরে কি, whenever seminiferous tubule will come in contact with testosterone, definitely that's a switch on signal for spermatogenesis, and that is happening over there. Clear? তাহলে Leydig cell ঢুকছে, and this testosterone paracrine effect, it is coming to the seminiferous tubule and helping in spermatogenesis, the process that we have discussed last day. So it is helping in the spermatogenesis. Now important clinical physiology over here. This is testosterone which is created in vivo. What about testosterone if we inject from outside? What it will do? Active manlam, pro-hormone. You know na, anabolic steroid or testosterone injection only can act. So what will it do? যদি exogenous testosterone, suppose if you are taking exogenous testosterone, what does that mean? Exogenous testosterone means from outside, like an injection form or something. You are taking the testosterone. What it will do? সেই যে testosterone টা হবে, exogenous testosterone, it will ignite, it will switch on the negative feedback pathway on LH. So testosterone যদি তুমি বাইরে থেকে নাও, that will act on LH, decrease the LH, and overall Leydig cell stimulation will come down. So overall testosterone function will come down. ওই জন্য যেটা হয়, testosterone has two types of action. One is in this in this reproductive action of testosterone. The other is anabolic effect of testosterone, in which the person gets bigger, more muscle mass, etc. Those are formed. Anabolic, that's the way they are taking. And anabolic part of the testosterone is more by the DHT, dihydrotestosterone basically. So এই বাইরেরটা নিলে ওটা ওই পাথওয়েতে বেশি চলে যায় rather than this pathway. So এইখানে দুটো পয়েন্ট লিখে রাখবে, exogenous testosterone is not well concentrated inside the seminiferous tubule, so it doesn't help much in spermatogenesis. In fact, it can reduce LH, therefore decreases the natural generation of testosterone and spermatogenesis. So exogenous testosterone can even cause infertility. তো যারা অ্যানাবলিক নেয় তাদের অনেক সময় দেখা যায় যে স্পার্ম কাউন্ট থেকে শুরু করে ফার্টিলিটি এভরিথিং গোজ ডাউন, এবং এটা কিন্তু একটা এক্সপ্লেন ওয়াই কোশ্চেন। সো এক্সোজেনাস টেস্টোস্টেরন নিলে দুটো রিজন, নাম্বার ওয়ান concentration হয় না, and the second thing, since testosterone is still available in blood, so it will be acting on the pituitary, it will decrease the LH by negative feedback, and subsequently Leydig cell will be working less, actual body natural testosterone will come down, so the spermatogenesis and stuffs will be down. So it has explain why exogenous testosterone can cause infertility. Explain why question. কোথায় কোথায় টেস্টোস্টেরন তৈরি হতে পারে? এক তো ইনসাইড লিডিং, অ্যাডিনাল কোথায়, কর্টেক্স কোন জায়গাতে, জোনা রেটিকুলারিস যেখানে সেক্স স্টেরয়েড তৈরি হচ্ছে। হাউএভার ওখানে যেটা বেশি তৈরি হয় দ্যাট ইজ ডিএইচইএ, সেটা বেশি তৈরি হয়, এপি অ্যান্ড্রোস্টেনিডর যেটা, সেইটা বেশি তৈরি হয়। এনিওয়ে, সো আমরা এবারে যাবো হচ্ছে টেস্টোস্টেরনের ক্ষেত্রে। সো ইট স্টার্টস ফ্রম কোলেস্টেরল, টেস্টোস্টেরন পাথওয়ে যেটা আছে ইট স্টার্টস ফ্রম কোলেস্টেরল, এবং নেক্সট পাথওয়েতে এটা যাচ্ছে হচ্ছে ইন দি প্রেগন্যানোলোন। বেসিক্যালি প্রেগন্যানোলোন থেকে আইদার ইট উইল গো ইনটু প্রোজেস্টেরন পাথওয়ে অর ইট উইল গো ইনটু ডিএইচইএ পাথওয়ে। এই জিনিসটার একটা, ইট ইজ আ ভেরি ডিফিকাল্ট এরিয়া, মনে থাকা একটু ডিফিকাল্ট হয়। আমি একটা খুব শর্টে একটা জিনিস লিখে দিচ্ছি, হুইচ উইল হেল্প ইউ ইন অল টাইপস অফ এমসিকিউস। এই জিনিসটাকে জাস্ট মনে রাখবে, একটা একদম শর্টে একটা জিনিস লেখাচ্ছি, and you will also remember all the enzymes which are acting over there. So first is cholesterol. কটা থাকে কোলেস্টেরলে? কার্বন। টেস্টোস্টেরনে কত থাকে? এটাকে লিখে নেবে, বইয়েরটা খুব ডিফিকাল্ট আছে। এটা একদম বেসিক, এইটা মাথায় রাখবে। এটা যদি মাথায় রাখতে পারো, পুরোটা রাখার দরকার নেই। বায়োকেমি ইউ নিড টু রিমেম্বার। দেখতে পাচ্ছ উই ডোন্ট রিমেম্বার দিস ডেজ, পরীক্ষার আগে একবার দেখে যেতে হবে বেসিক্যালি, আদারওয়াইজ ইটস ভেরি ডিফিকাল্ট টু রিমেম্বার বেসিক্যালি। বেসিক আইডিয়াটা এখানে বুঝতে হবে যে কি থেকে কি হচ্ছে। ইট স্টার্টস ফ্রম কোলেস্টেরল and there are two pathways. কোলেস্টেরলটাকে ফার্স্ট ইট নিডস টু বি কনভার্টেড ইনটু প্রেগন্যানল। সেটা কোথায় হচ্ছে? ইন অ্যাড্রিনাল কর্টেক্স। দিস ইজ হ্যাপেনিং ইন দি অ্যাড্রিনাল কর্টেক্স। এইবারে দিস প্রেগন্যানল ইফ ইট গেটস 3 বিটা হাইড্রক্সি স্টেরয়েড ডিহাইড্রোজেনেস, তাহলে ওটা প্রোজেস্টেরনের দিকে চলে যাবে। If it gets 3 beta hydroxy steroid dehydrogenase, it will move into progesterone line. যদি it gets 17 hydroxylase, তাহলে it will move into 17-OH pregnenolone. These two lines are different. Now 17-OH pregnenolone সেইটা লায়েজ এনজাইম যদি পায় তাহলে DHEA তৈরি করবে। লায়েজ এনজাইম যদি পায় it will go into DHEA. DHEA ultimately will go into androstenedione. Androstenedione is the common precursor of testosterone. যদি androstenedione না পৌঁছানো যায়, it will not move into testosterone. And from various pathways, if it can come to the androstenedione, it will move into testosterone. তাহলে এই যে T লিখছি, T-টা হচ্ছে testosterone. Similarly দেখো, progesterone can also go into 17 hydroxy progesterone. যদি ওখানে 17 hydroxylase থাকে, it will move into 17 hydroxy progesterone. 17 hydroxy progesterone can also move into androstenedione. তাহলে that is one pathway যেটা কোলেস্টেরল থেকে প্রেগন্যানল, প্রোজেস্টেরন হয়ে এর হাইড্রক্সিলেশন যদি হয়, প্রোজেস্টেরনের যদি 17 হাইড্রক্সিলেশন হয়, তাহলে it will move into androstenedione and further down the line it will go into testosterone. If 17 hydrox position hydroxylation হচ্ছে না, in that case it will move into formation of other steroids. Those are the mineralocorticoids. সেই লাইনে ঢুকে যাচ্ছে। মিনারেলোকর্টিকয়েডে প্রোজেস্টেরন ঢুকছে, দুটো পাথওয়ে আছে, অত ডিটেইলে আমি যাইনি। ফার্স্ট পাথওয়ে হতে হবে 21 হাইড্রক্সিলেজ এনজাইম, সেটার ডেফিসিয়েন্সি তো কিছু সময় এই দিকটা বেড়ে যায়, ভিরিলিজম এটসেট্রা আসবে। আরেকটা হচ্ছে ডাউন দ্য লাইন 11 বিটা হাইড্রক্সিলেজ, সেইখানটাতেও যদি ডেফিসিয়েন্সি হয়, এগেইন ইট উইল গো ইনটু দি আদার টু লাইনস, গ্লুকোকর্টিকয়েডের দিকে যেতে পারে অথবা 6 স্টেরয়েডের দিকে যেতে পারে। যদি এই দুটো both of these 21 hydroxylase proper কাজ করে and 11 beta is working properly, then it goes into the aldosterone. Aldosterone কোথায় তৈরি হচ্ছে? Aldosterone is happening in zona glomerulosa, একদম আউটার। Aldosterone is a mineralocorticoid. Aldosterone is a mineralocorticoid, সেখানটায় এটা তৈরি হচ্ছে। So this is the basic, এইটা মাথায় রাখতে হবে কোন এনজাইম থেকে কোন দিকে ঢুকে যাচ্ছে। So main thing is you need to know about desmolase. First one is pregnenolone, you need to know about it. Oh, time is up, I think. Sir, এসে গেছে নাকি? আসেন। Pregnenolone থেকে 17 হাইড্রক্সি এদিকটায় যাচ্ছে, এইটার একটা পিকচার অলরেডি আই থিংক হয়ে গেছে, এই জায়গাটা মাথায় রাখতে হবে। So I think this is sufficient for today. যে পার্টটা বাকি থাকলো, that is the function of the testosterone. Function of the testosterone, function of dihydrotestosterone. So এটা after Diwali. Happy Diwali to all of you. বাড়ি যাচ্ছ, ফিরে এসো।
To our house for the Diwali vacation. We are going to have a small topic on developmental aspects on the embryological understanding, and which is a kind of like a very obvious birth defect which is embryologically happening, which is projected out here. It's a kind of one of the commonest kind of facial defect which commonly encountered, and this kind of like the facial defects is pretty common for every one of us. We have seen many of our neighbors and in the localities and everywhere we have kids who has this kind of defects in the face. So these kind of facial defects, we call them as cleft lip, which is visible through these particular lips, which is the upper lip most commonly affecting. We call them as cleft lip, right side, left side, like it's unilateral, bilateral, median, lateral, etc., etc. So this is a one-side cleft lip, or which is a lip has a defect in the upper side. This one, which is having a both side, which is having a defect. This one is an aggressive variety of the cleft lip defect, which is extending upwards, where the palate, the hard palate, is a defective in this particular form. So today's discussion topic is about the development of the face, which is basically very small discussion, and this particular facial development involves this particular problem, which is known as cleft lip, cleft palate understanding, and which is our exam question. That's why we have focused this entity to understand here. So the learning objective of this session is we have to know why this kind of defects is happening and who are the susceptible individuals, the kids who are having more chances of having this kind of defects, which is known as cleft lip defect and the cleft palate defect. So to know and understand this, we have to understand this particular process of facial development. And for understand the process of development, we must have a basic very idea about the lip, which is involved in the upper lip. So we have to know about very little precise information of the upper lip parts. Here we have the upper lip, which is already been covered in the face. I'm just like reiterating the thing. You see this part of the lip, upper lip, the central part of the upper lip has a special name. We call it the philtrum. So this particular philtrum and this particular region, we call them as vermilion border of the upper lip. So right side, vermilion border of the upper lip, left side, vermilion border of the upper lip. So this is about the upper lip has got these domains or these segmentations, this understanding we have to have. So which part is philtrum and which part is upper and right and left vermilion borders. Lower lip compared to it, we have this particular vermilion border, which is a continuous thing. We do not have a break in between. So having the break in the upper lip, we have to know about these particular different parts of the upper lip. So once you know about this particular philtrum and the vermilion border, upper and the lower, we have to know this particular facial development where from the face develops. So you're going to know about this particular upper lip of facial development. Then we're going to talk about the development of the palate. So we have the palate to understand, and we have to understand this particular lip, and again we have to understand this particular part of the facial development, which is having some kind of anomalies, which is cleft lip and cleft palate. So those are the short questions could be given in the examinations. So let's begin with this particular thing, which is known as the development of the face. So whenever you are going to understand this development of the face, there are three elements which are playing roles in case of the face development. One is the central part, three components out of that. One we call them as frontal nasal prominence. If you know this particular name, frontal nasal prominence, number 2 and number 3, these are easy things. We call them as maxillary prominence. And then down here we have the mandibular prominence. So these three segments or entities, they interact with each other and give rise to the formations of the face. If there is a failure of interactions among them, we have a defect or the kind of birth defect, which is reflected as the birth defect problem, which we're going to talk about. Now, we talk about this particular prominence, we call them as frontonasal prominence, which is present in the front side, which is in the midline, frontonasal prominence. So, we have a future mouth region, which you can see in this particular picture, is shaded with the dark region. So this particular future mouth region, which is shaded in the midline, we call them as stomodium. So stomodium is the future mouth, which is going to develop into the mouth or oral cavity in our regions. So surrounding this particular stomodium, we have these three guys appears around or beyond 4 weeks of age. So once the 4 weeks gets progressed, we have this particular bulges coming out and making some kind of projections. So you have three projections, one on the top, two on the side, upper and the lower. These are the three projections. That's a single thing which is happening around the future mouth region. So stomodium, which is the black shadow, surrounding which we have the midline projections, and we have these particular bulges coming on the upper and lower tones. We call them as frontonasal prominence, and as well as we call them as maxillary prominence and mandibular prominence. These are the three things which is kind of important to us. Now we focus in this prominence, which is the frontonasal prominence, which is the midline prominence, and which has some development to develop with. So this frontonasal prominence, as you split the name, splits into or develops into complex structures. So this frontonasal prominence has a midline bulge which is coming out, develops in a cavity or a depression. That particular depression which is present on this particular frontonasal prominence, we call them as nasal placoid. So we have a thing which is coming on this frontonasal prominence, which is bulging on the sides like this. Eventually, to give rise to bulge, we call them as nasal placoid. So these are the two bulges, we call them as nasal placoid, which is a further development from this frontonasal prominence. Within this particular nasal placoid, you can see there are two placoids on the right and the left. Within this right and the left, there appears a depression in it. The depression which is present in it, we call them as pit. So this particular pit, we call them as nasal pit. So as because this nasal pit appears, it splits this particular nasal placoid into two entities. One is a medial half and other is a lateral half. So medial half and lateral half of nasal prominence. Now with time, what we see here, this medial half of the right side and the left side comes closer and gets clogged eventually and gets fused and makes it common mass. Now this particular common mass which is formed here, we call them as intramaxillary segment. So this particular intramaxillary segment, which is formed by fusion of this medial nasal placoid, interacts with these maxillary prominence or maxillary process. That's why it's called intramaxillary prominence. Give rise to the formations of this particular upper lip. So this is what we are going to understand. This is what we are going to see. Now let's look into this thing, whatever we are seeing here. We have three prominences to start with: frontonasal prominence, maxillary prominence, and mandibular prominence. These three guys giving rise to the formations of entire face region. So we take this frontonasal prominence. Within this frontonasal prominence, we have a bulge or disc appears. That disc we call them as nasal placoid. That particular nasal placoid, which is a bulge over here into here, we have a depression. We call them as nasal pit. Having this nasal pit, this nasal placoid, it's split into two segments. We call them as medial half and lateral half. We have two color shades used in here within this particular nasal placoid, green and the purple. So the green one is the medial nasal placoid or the mesial part or medial nasal prominence. The purple one is known as lateral nasal prominence or lateral nasal placoid. Here. Now with subsequent time, this green guy, right side and left side, further close and meets with each other and joins and makes a common mass. That particular common mass, we give a special name to it. We call them as intramaxillary segment. Now once these things are formed, you can see this orange tissue, which is the maxillary prominence, and this red one is the mandibular prominence. So this orange guy, right side, left side, two maxillary prominence, moves closer and meets with the green guy and makes this particular upper lip. So this is how this upper lip is formed. Compared to this right and the left, red side, which is the mandibular prominence, they come closer and forms the lower lip and the jaw. So this is how this part of the face, which is involving the nose or tip of the nose, upper lip, and this particular segment which is formed. Now, this is what we are saying. This is falling in sequence. So this particular prominence, green one, medial nasal prominence. Purple one, lateral nasal prominence. Medial one comes together, forms a mass. We call them as intramaxillary prominence. Within this intermaxillary prominence, there is an interaction of this orange tissue, which are the maxillary prominence. The maxillary prominence interacts with the intermaxillary process and joins with each other, and eventually turns up into this particular face region, the cheek, which you can see formed by the maxilla over here, and this part of this particular upper lip. Now you can see this particular upper lip, which is having two shades. One is green in the midline and this orange on the sides. So coming back to think whatever we have learned about this particular basic architecture of the lip in the upper region. So the midline part of this particular lip, we call them as philtrum, and this one we call them as barbilian border, right and left of this philtrum. So if we just compare with this particular picture, which is around the 10th week of time of the development of the face, you see this midline, which is a philtrum, which is formed here, and it is green shadowed. That means that green shadowed part is coming on the interactions of intermaxillary segment. And who forms the intermaxillary segment? Which is the medial nasal prominence. And where from this medial nasal prominence is coming? It is medial nasal prominence coming from frontal nasal prominence. So these things are happening and falling in sequence, and that's how these things are formed. So this particular medial part, which is known as intermaxillary process, joins with this orange part, which is maxillary prominence, forms this upper lip. If you look at the lower lip, the red thing, the jaw and the chin, this part along with the lower lip is formed by this orange one. What is the orange one? Which is known as mandibular prominence. Right side mandibular prominence, left side mandibular prominence. Forms around this particular black shadow over here. What is the black shadow? Future mouth. So this part we call them as stomodium. So stomodium around here, this phenomenon is taking place. So these things happening around 6 weeks, 7th week, 10th week, we have a face largely, more or less completely developed. So this is how these lips are developed and the face is developed. This part, which is having this particular cheek region developed from this maxillary prominence, the jaw and the lower part is formed over here by this particular mandibular prominence. And if you look at this nose, you can see this nose is formed by this purple and this particular green shadows. So this green shadow is intermaxillary segment, which is like medial nasal prominence. So this particular central part of the nose, which is coming from this particular root up to this tip of the nose, the central region, which is formed from the fusion of the maxillary medial nasal prominence, the sides of the nose, which is known as ala of the nose, which is formed by the contributions from this purple shadow. What is the purple shadow? This purple shadow is coming from the lateral nasal prominence. So this nose and the upper part of the cheek and this jaw is formed by these three prominences, the interactions between them. Now, if we have any error in the interactions between these three elements, we might have some kind of developmental error or congenital error, which is the cleft lip, the cleft palate, etc. So we focus out here the developmental process of these lips and go back to this particular error on here, we can see this. So you see that whenever you are given this particular picture to decide with which part of this developmental segment is messing up with this kind of problem, you have to look at this upper lip. Now if you see this particular upper lip, it's contributed from two elements. One is the philtrum, which is developing from the intermaxillary segment, which is coming from the union of the medial nasal prominence. The sides of this philtrum, right side and left side, is coming from the maxillary prominence. So if we have a gap in the upper lip, which is present strictly into the midline, that means over here, which is a narrow gap which you're seeing here, the philtrum gap, that means there is a fusion defect of intermedial nasal prominence or intermaxillary segment. If you have a gap on the sides of the philtrum, right side, left side, like this, that means the lateral nasal prominence, this medial nasal prominence is failing to meet with the maxillary prominence. That's why we have a gap in this particular part. So depending on right side, left side or bilateral side, whichever the part is deficiently aggregating with each other, we have a birth defect. So we have this particular clinical problem, which is our exam question actually, is this one. We call them as cleft leaf, cleft palate. There are two varieties of the cleft leaf is there. We call them as median cleft leaf. That means it's restricted to the philtrum. That's why you call them as median cleft leaf. It's involving this philtrum. If the philtrum is split, that means the intermaxillary segment is not formed completely. Other variety of the cleft leaf, the lateral leaf, which is known as lateral cleft leaf. That means the philtrum is rightly formed, but the fusions of the philtrum with the Marmelian border is deficient. That means the maxillary prominence, which is coming, should be coming over here, meeting with it, mingling with it, blending with it, is deficient. That's why we have a gap here. So maxillary prominence with the medial nasal prominence doesn't match with each other, leaving a gap. We call this as lateral cleft leaf. So these are the two entities. Now, what we will be given in the exam to understand or write about, write a short note on the developmental error of cleft leaf. So we have to see this particular cleft leaf. You have to just like to see this particular cleft leaf. This particular cleft leaf is a multifactorial element. That means it may be chromosomal, may be environmental, may be drugs, intrauterine life the patient may have consumed that might have triggered some kind of fusion defect. Now, who are the susceptible individuals to have this cleft leaf? The kids, which are more in happening here, is a male individual. The male kids are more predisposed to have this kind of cleft leaf defect. So, this incidence is 1 in 1,000 births, which is quite high. So, there is an incidence which is of the cleft leaf is related to the increased maternal age. The maternal age more than 40, that means high maternal age, there are more chances of kids to develop with this kind of birth defect. So this is the basic thing about this particular cleft leaf. Now, coming to the classifications of the cleft leaf, there are two varieties of the cleft leaf there. One is median variety, lateral variety. What happens with the medial variety? What happens with the lateral variety? You have to explain. And why these things are happening? There is a fusion defect between this particular intermaxillary segment, or the intermaxillary segment is failing to fuse with maxillary prominence on the right or the left side, leading to this kind of thing. So these are the things which you have to narrate and give a little description over here with a schematic or any kind of pictures which is given. So this is about the cleft leaf. So far, any doubts or any queries? Plain and simple things. Three things you have to remember. These prominence, how they are reacting, and what are sequence things which is happening. Stage 1, stage 2, stage 3. Stage 1, medial nasal prominence. Joins with each other, intermaxillary segment. Intermaxillary segment forms the philtrum. Intermaxillary segment should be interacting and blending with the maxillary segment on the right and left side, leaving no gap in between. If this union is having some kind of defect, maybe you have a cleft leaf here on the cleft leaf on the left side, depending on the side, which is interactive deficiency are there. And more common in Melbourne, more incidence of the cleft leaf formation happens to occur in case of this particular maternal age, which is exceeding beyond 40 years, we call it high maternal age, and this is quite high in incidence, 1 in 1,000 births. Now, every 1,000 kids born, one kid is born with this kind of facial defect. Now, how to treat this? We do not have any medicines, the blue, orange, or red will cure this. We have to surgically intervene, suture it, grease it, and do the networking so that this particular thing is completely repaired well. Now, what is the defect is left with? The kids have a problem with the phonation, or may the kid have a problem with this chewing. Food materials may be coming out. The air may be getting out, so the phonations may be deficient. And moreover, it's a kind of facial disfigurement. So socially, the patient or the kids are aloof or kind of like a little bit pushed back. So there's a social acceptance problem is there along with the kids who are having this kind of defect. So we have to correct or rectify it. right? So this is about the lip and the facial development, which is related to it. Now, other variety of this particular thing which you're going to see or going to talk. Development of the palate. So we have the palate which is soft and a hard palate. So this particular palate, soft and hard, we call them as in the gross anatomy. Whenever you're going to talk in embryo, we call this palate as the primary palate and the secondary palate. So there are two elements embryologically exist, primary and the secondary. Primary palate develops from one source, secondary palate develops from one source. Again, that's very easy. You have to remember two pieces of information. Majority of the work is already done. Again, everything in the face region is involved in these prominences. Frontonasal prominence, axillary prominence, and the mandibular prominence. So out here, whenever you're going to talk about the palate development, these front two, the frontonasal prominence and the maxillary prominence, the interactions of these two play the role. Now, as I mentioned, this palate has the two parts, primary palate, secondary palate. So, what is the primary palate? This part of the chunk of the tissue which you're seeing here, forming this primary four tips, which is inside the tips, present in the front, four tips. And involving here is a cake piece over here. Following here, we have a foramen. We call them as incisive foramen. Involving here, we have this triangular area. This little area, we call them as primary palate. And the rest is secondary palate, or the palate which you have seen. So, the secondary palate and the primary palate is sourced from different elements. So, this particular different element coming from where? The same tissue where we are talking about. Now, this particular area, which is known as primary palate, the primary palate is formed by the same thing, which is known as the intermaxillary segment. So, this what is intermaxillary segment? Once again, these two tissues, medial nasal prominence, joins with each other, gets this particular intermaxillary segment. From this intermaxillary segment, three things develops. One is the filtrum part of the upper lip. Second thing, the four inside the tip, the four front tip is developed from that particular intermaxillary segment. And this primary palate. These are the three things developed from this intermaxillary segment. So, this intermaxillary segment out here makes this particular primary triangular shaped palate. Now, this particular region which you see here in the black or dark shadows, which is the secondary palate. How the secondary palate is formed? Secondary palate is formed from the two tissues. We call them as palatine shells. Now, palatine shells develops from the maxillary prominence. So, eventually, these two, the frontonasal prominence and this particular maxillary prominence, play the role in formations of this palate. So, coming over here, this central part, which is known as the primary palate. How this primary palate is formed? Interactions of the right and left medial nasal trichord forms the intermaxillary segment, give rise to three tissues, four inside the teeth, this particular primary palate, which is over here, and this particular region of this lip, which is known as filtrum. Next is the palatine shelves. Who makes this palatine shelves? Right side maxillary prominence, left side maxillary prominence. They come from different regions, right side, left side, over here, bridge with each other initially, and then bridge with this particular primary palate, leaving no gap whatsoever. This is how it is formed. Now, any error in the formation of intermaxillary segment, any error in meeting of this palatine shelf with the primary segment leaves a gap, just like gap left in the lip. If a gap is left in this palate, we call them as cleft palate. That's the simple thing about the development of the palate. So again, primary palate, secondary palate. In case of this gross anatomy, we call them a soft palate, hard palate. In embryology, we use the term differently. Primary and the secondary. Primary palate sourced from region, secondary palate sourced from other region. Primary and secondary mix with each other, makes a whole palate. Now, if you have any interaction error between them, we have an embryological error, which is the cleft palate, which we are talking about. Now, this one central part, intermaxillary segment, fails to unite over here, you may have a gap in this particular region. So that particular gap in this particular primary region, we call them as cleft palate. Now, if we have a gap on this particular region, we also call them as cleft palate, right side and left side. Maybe this particular gap is partial or maybe complete. So we call these, or nomenclature A, partial cleft palate or complete cleft palate. So how are we going to know? You have to ask the patient to either make him cry or her cry, or ask him to open the mouth. Once they open up the mouth, things are clear to us. Once the patient opens the mouth, you can see this particular leaf, palate, how slit they are. If it is complete slit or partial. If it is a right side, left side meeting error, or it's a medial segment error. It is a primary error which is involving this particular region of this particular palate, or if it is involving in the back here of this particular palate development. So this is how we are going to talk about this development of the palate. So primary and secondary palate and these particular fusions of this particular problem. Now if we have an error in this particular problem of this fusion, we have this particular region. We call them as cleft palate, primary or secondary or complete or partial. If it is all throughout, the picture you are seeing, this is a complete cleft palate. All throughout, even this soft palate uvula is split. So it's a complete split, even the uvula which is hanging down, it's right side and left side split. So it's a complete cleft palate. Compared to over here, it's a posterior cleft palate which is partial, which is affecting this palatine shell. That means palatine shell means we have error in the maxillary prominence. If you have a defect in this region, front side, that means we have the primary palate defect. That means the intermaxillary segment or medial nasal prominence is fairly diffuse. Now coming again, you are given the short note, cleft palate. How are you going to address? So you have to say about what is cleft palate. It is a split embryological error which is existing in a newborn. The incidence is less common than that of like a cleft lip, 1 in 2,000 or 2,500 in a live birth. That means every 2,500 kids born or 2,500 or 2,500 kids born, we have a case of this particular cleft palate which is existing. Now this particular cleft palate is more common in female individuals like kids. Female kids are more propensity to have this particular defect compared to this with the lip, which is the more in case of male born kids, which is having more chances. And there is a relationship of this particular cleft palate formation to taking up in utero position drug. That means when the kid was in mother's womb, if the mother is suffering from any kind of error, which is a convulsion error, we give some drug to control the convulsions, which is known as this anti-convulsional drugs. So those drugs are said to be or linked to be interacting with this meeting of these particular palatine shells, and that leads to more chances of formations of this particular cleft palate error. So this is about this particular cleft palate. Coming to the classifications, either it may be primary palate or secondary palate error, which may be partial or maybe complete error, which is happening over here. How these things are formed? If it is this particular problem with this definitely, if it is a primary palate error, that means intermaxillary segment is not meeting the right side, left side. If it is secondary palate defect, that means we have the palatine shelves are not coming. That means the maxillary prominence of the right and left not meeting properly, leaving a gap over here, and that leads this particular problem. Now, how are we going to treat this? Now again, we do not have any medical treatment for it. We have to repair this surgically. Suture it, fuse it, and do the corrections with the surgeons. Now what if you leave this particular person with this kind of defect, because this kind of little bit defect is a little bit hidden, which cannot see it properly until they open the mouth. So we can leave these particular defects. But this again leads to the problem with this chewing problem. It may be leads to the problem with the phonation. It leads a problem with this kind of more chances of infection, because this particular hard palate is related to this particular nasal cavity. So chances of food material can be leaking into this nasal cavity, and chances of infection to the nasal areas, and at the same time can infect this particular nose to this particular palate region or oral cavity region. So we have seen a patient who was coming to our clinic with this kind of defect, whatever the food the person is taking coming out through nose because of this particular problem. Because of this particular problem, which is a complete split over here. So food material from here leaking into nasal cavity coming through nose. So these are the complications or could be a presentation to you with this kind of defects. So this could be exam short notes involving this face and facial development, cleft lip and the cleft palate. Prepare that well and talk to your friends if you have understood these particular defects, what kind of defects or not, what are you going to write it, how are you going to write it, and remember this, give or drop a schematic picture of these particular problems if it is given to answer in exam. And that's all for the day.
What? Is that what? Really? I'm good. What with you? Do something. I'm going to do it. What is it? Go ahead. 남기가 되는 시간이 잡기 보는 거. 저녁에 되면 안 되고 이거는
part of the pharynx, do you know? Guess what? Nasopharynx, oropharynx and laryngopharynx. Okay? Okay? Pharynx is musculo-membranous tissue. Okay, so it has got muscle as well as membrane. কোথা থেকে কোথায় extend করে? Up to the base of the skull, up to the cricoid part. তো যদি তোদের আমি রিলিজ করি larynx কোথায় extend করে তাহলে larynx বল extension of larynx বলেছি এর আগে ক্লাসে between the C3 to C6. Okay, so pharynx is extend from the base of the skull up to the C3. Okay, up to the C6, same level. Okay, but larynx is C3 to C6. So larynx should be situated anteriorly or posteriorly? Huh? And larynx আগে থাকে না larynx আগে থাকে? Pharynx টা পিছনের দিকে থাকে. Okay, first of all, because pharynx is a continuation of esophagus. Okay, anteriorly কি পাই আমরা tracheostomy পাই, trachea পাই এখানে, right? Trachea টা extend করছে কি next part larynx. Okay, larynx টা extend করছে as a trachea. Okay, so anteriorly there will be larynx and trachea, posteriorly there will be pharynx and esophagus. Okay, so it's a median passage. Okay, for it is common for elementary as well as the respiratory tract. ঠিক আছে, তো কোন পার্টটা হচ্ছে এলিমেন্টারি ট্র্যাক্টের পার্ট, কোনটা ডাইজেস্টিভ ট্র্যাক্টের পার্ট? nasopharynx is a part of respiratory tract, oropharynx is a part of alimentary tract, laryngopharynx again it is a part of digestive tract. Don't think it is a part of respiratory tract. Okay, laryngopharynx is not a part of respiratory tract, but it has got a common connection. There are two connections. Okay, between the nasopharynx and oropharynx there is soft palate. Okay, and between the oropharynx and laryngopharynx there is epiglottis. Okay, so this is the main difference. Okay, so next, so see, this is the pharynx. So we could see it is extending from the base of the skull up to the cricoid cartilage. Okay, so here which one is the nasopharynx? See, this is the soft palate what I am talking about. This is the hard palate, and back of this is the soft palate. So this soft palate is acting as a spring door. Okay, it is closing whenever we are eating any food. Okay, it is closing so that no food particle could go to the nasopharynx. Okay, and what is this? This is the epiglottis. Okay, this leaf-like structure is the epiglottis. This epiglottis will come here. Okay, so that no food particle could again enter to the larynx. অনেক সময় আমাদের কি হয়, জল খেতে গিয়ে অনেক সময় অ্যাসফিক্সিয়া হয়ে যায়, জলটা ল্যারিংসে চলে গেল, ল্যারিংসে গেলে কি হবে, সেটা লাংসে গিয়ে আবার সেটা নিউমোনিয়া করতে পারে। বুঝতে পারলি? So that's why this epiglottis and soft palate is very much important. Okay, and এটা কি, এর আগে দিনই আমি যেটা বলছিলাম lacrimal duct. So lacrimal ductটা কোথায় ওপেন করে বললাম, inferior hiatus. So এই যে তোরা এলিভেশন গুলো দেখছিস এগুলোকে কি বলে, এগুলোকে বলছে টার্বিনেট। ওকে, এলিভেশন যে বডি এলিভেশন গুলো দেখতে পাচ্ছিস সেগুলোকে বলছে টার্বিনেট। এবং in between we are seeing this depression, these are known as hiatus. Okay, so there would be no confusion. Elevation is known as turbinate and these depressions are known as hiatus. এবার এগুলো যে তিনটে নাম দিই, superior, middle, inferior, again superior, middle, inferior. Okay, so this nasolacrimal duct will open here. What is this? This is the opening of eustachian tube or PT tube, যাকে আমরা বলছি pharyngotympanic, because it is connecting with the nasopharynx up to the tympanic, মানে কি, tympanic cavity of the middle ear. Eustachian tube নিশ্চয়ই জানিস, what is the function? To maintain the air pressure of the barotrauma. Okay, if you are flying in a flight, at that time there is tremendous air pressure. Why? Because the partial pressure of oxygen is increased or decreased. Oxygen, partial pressure of oxygen, যত আমরা উপরে যাই এটা বেড়ে যায় না কমে যায়, বেড়ে যায়। ওকে, সো দ্যাট উইল কজ দ্য barotrauma. ওকে, সেজন্য আমরা কি বলি, সব সময় কানে একটা হেডফোন নিতে অথবা চিউইং সামথিং। ফ্লাইটে এমনি এমনি চকলেট গুলো দেয় না, কেন দেয়? টু প্রিভেন্ট দিস থিং। ওকে, সো দ্যাট দিস eustachian tube would not be blocked. হ্যাঁ,
আবার যেন ফ্লাইটে চড়ে তাই জন্য দেয়।
হ্যাঁ, ওটাও হতে পারে, ওটাও হতে পারে। আচ্ছা, রিলেশন কি কি আছে? অ্যান্টিরিয়রলি তোরা দেখলি, অ্যান্টিরিয়রলি কি আছে, নেসাল ক্যাভিটি, ওরাল ক্যাভিটি। ওকে, পোস্টেরিয়রলি কি আছে, কানেকটিভ টিস্যু এন্ড দি প্রিভার্টিব্রাল স্পেস। ওকে, এবং পোস্টেরিয়রলি আমরা যে ডিপ সার্ভাইকাল ফাসাগুলো পেয়েছি সব কটা পাবো, ঠিক আছে, প্রিভার্টিব্রাল ফাসা এন্ড দ্য সার্ভাইকাল পার্ট অফ দি ভার্টিব্রাল কলাম। ওকে, পিছনের দিকে ফ্যারিংস কোথায় আছে আমি অলরেডি বলে দিয়েছি, পিছনে মোস্ট পোস্টেরিয়র স্ট্রাকচার। ঠিক আছে, এবার যখন আমরা স্যাটাইটাল সেকশন অফ নেক করব তখন অলরেডি আমরা দেখতে পাবো ফ্যারিংস। ঠিক আছে, ফ্যারিংসে থাকবে মোস্ট পোস্টেরিয়র স্ট্রাকচার। ঠিক আছে, যার তার পিছনে কি থাকবে, শুধু ভার্টিব্রা আর ইন্টারভার্টিব্রাল ডিস্ক। ওকে, সো সি, দিস ইজ the nasopharynx, this is the oropharynx, and this part is the laryngopharynx. Why it is called laryngopharynx? This is just posterior to the larynx. এখানে দেখতে পাচ্ছিস larynx, it is just present posterior to the larynx. Okay, so superiorly কি কি থাকছে, superiorly থাকছে basi, sphenoid and basi occiput. These are the part of the base of the skull. Okay, and inferiorly it is continuous as esophagus. Esophagus is length কত, esophagus এর length গুলো ইউজ করি, pharynx এর length কত, pharynx এ কটা ওয়ার্ড আছে, হ্যাঁ, টেবিলে কি আছে, FHA Okay, so it is related to the semen. Okay, length is approximately 6.5 to 7 centimeter. Okay, and how many muscles are there? There are 6 muscles. কি কি আছে? তিনটে কনস্ট্রিক্টর আছে, সুপিরিয়র, মিডল আর ইনফিরিয়র। আর তিনটে ফ্যারিঞ্জিয়াস মাসেল আছে। কি কি ফ্যারিঞ্জিয়াস? একটা হচ্ছে স্টাইলোফ্যারিঞ্জিয়াস, গ্লসোফ্যারিঞ্জিয়াস এন্ড প্যারাফ্যারিঞ্জিয়াস। ওকে, আমরা ওখানে মাসেলে আসছি নিচে। ওকে, so see, if we cut or have a sagittal section of pharynx, কি কি পাবো? What are these? These are the concave. Concave means কোনটাকে কনকেভ বলে? nasal cavity টা আমাদের anterior nostril, posteriorly যদি দেখি, posteriorly will get this space. Okay, these are the posterior nostril or one. Okay, then next one would be, this is the epiglottis. What is this space? Do you know? It is known as pyriform fossa. Okay, it is known as pyriform fossa. This space, this is epiglottis. Just back to that. Why it is important? If you are taking any food like fish bowl, could be chicken bowl, whatever. Okay, that would be common lodgement site would be pyriform fossa. Okay, everybody has experience, right? কোথায় গিয়ে আটকায় মনে রাখবি pyriform fossa. Okay, and back of that, this is the esophagus. So nasopharynx definition is, it is a nasal part with the nasal cavity opens. Oropharynx, where the oral cavity opens, or the posterior part. And laryngopharynx, it is just in front of the larynx and below is with the esophagus. Okay. So same thing they have shown. What is this structure? ये क्या है? This is the tongue. Okay. So just think about the tongue posteriorly, how it is attached. Okay, and this is the superior border, which is this bone. It is the mandible. Could you remember the genioglossus? Okay, so this muscle, it is the safety muscle of tongue. ঠিক আছে, যখন কোনো মানুষ আনকনসিয়াস থাকে, রাইট, তখন তো তার কোনো কন্ট্রোল থাকে না। সো দিস টাং কুড ফলো, means fall down in the oral cavity, and it could also got asphyxia. কেন করে না? বিকজ অফ দিস সেফটি মাসল দ্যাট ইজ নোন অ্যাজ জিনিওগ্লসসাস। যে কারণে দেখবি পেশেন্ট অপারেশনের পর পোস্ট অপে আমরা বলি প্লিজ টেক হিম টু দ্য ব্রেন দ্য সাইড। ঠিক আছে, ফার্স্ট অফ অল তাকে ল্যাটারালি শোয়াতে হবে এবং দেখতে হবে কোনোভাবেই যেন টাংটা ভেতরের দিকে না। ঠিক আছে, কারণ এই জন্য পোস্ট অপ কেয়ারটা খুব ইম্পর্টেন্ট। ঠিক আছে, নিজের অনেক সময় কি হয়, নিজের স্যালাইভা সে গিলে ফেলতে পারে, সেটা কোথায় যেতে পারে? ল্যারিংসে যেতে পারে, কারণ এখানে কোনো কন্ট্রোল নেই, পেশেন্টটা আনকনসিয়াস। বুঝলেন? এই জিনিসগুলো পোস্ট অপে কেয়ার করতে হবে। নাও ফ্যারিঞ্জিয়াল ওয়াল, যদি আমরা ফ্যারিংসের পোস্টেরিয়র সাইড দেখি, অ্যান্টেরিয়র সাইডে কেটে দিলাম, রাইট, পোস্টেরিয়র সাইডে তাহলে কি পাবো? ফার্স্ট ওয়ান ইজ would be the pharyngeal isthmus. Okay, so what is pharyngeal isthmus? It's a communication between the nasopharynx and oropharynx. Okay, and it could be closed during swallowing. So isthmus মানে কি? It is the common part between the nasopharynx and the oropharynx. Okay, now which one is the palatopharyngeal sphincter? এখানে একটা MCQ আছে, what is passavant ridge? Which one is the passavant ridge? এটা বলছে it is one kind of muscular fiber, okay, which will contract when there will be any food or deglutition. Okay, at the time of deglutition. এটা কিছুই না, এটা একটা muscular fold in the posterior wall of the pharynx. এই রিজটাকে কি বলছি আমি? passavant ridge. Passavant ridge. Okay. Okay, so that এখানে হচ্ছে this is known as the pharyngeal isthmus. Okay, so above that there would be so many structure. Okay, first of all there would be one, কতগুলো টনসিল থাকে? Do you know কতগুলো টনসিল থাকে বল? 4টা না 6টা? There would be 6 tonsils. Okay, which are they? প্রথমেরটা হবে ফ্যারেঞ্জিয়াল টনসিল। ওকে, এখানে যেটা দেখতে পাচ্ছিস একটাই থাকবে। ওকে, দেন देयर উইল বি টু প্যালেটাইন টনসিল। ঠিক আছে, প্যালেটে দুপাশে থাকবে। ঠিক আছে, দেন देयर উইল বি টু টিউবাল টনসিল। ওকে, and there will be one lingual tonsil. এগুলো কি করছে? wall layer ring of defense. What is that? Any kind of infectious disease, this tonsil will be swallowed. আমাদের কোনটা খোলে, কোন জায়গাটা আমরা বাচ্চাদেরও দেখি, ঠিক আছে, সেটা মনে রাখবি। সেটা একটাই থাকে, যেটাকে ফ্যারেঞ্জিয়াল টনসিল বলছে, এটাকে অলসো অ্যাডিনয়েডস বলছে, অ্যাডিনয়েডস বলছে। ঠিক আছে, তো সেক্ষেত্রে যদি কোনো বাচ্চার অ্যাডিনয়েডস থাকে তাহলে কি হবে? there will be snoring. Okay, and there will be obstructive sleep apnea. Obstructive sleep apnea মানে ঘুমের ঘরে হঠাৎ এখানে আওয়াজ হবে। Okay, that is due to enlarged pharyngeal tonsil. Quadratus ring of defense টা আছে কিন্তু pharynx। ঠিক আছে, এই ছটা টনসিল কি করে এখানে থাকে। ঠিক আছে, আচ্ছা এখানে আর কি কা বল। হ্যাঁ হ্যাঁ,
ওই টনসিলে এগুলা অবস্ট্রাকটিভ স্লিপ
obstructive adenoids, adenoids ওটা হচ্ছে adenoids এর জন্য হচ্ছে। ঠিক আছে, আচ্ছা দেখ এখানে যেটা দেখাচ্ছে এই রিজটার কথাই বলছি। ঠিক আছে, এটাকে কি বলছি আমি? প্যাসাভেন রিজ। প্যাসাভেন রিজ এটা পোস্টেরিয়র ওয়াল অফ ফ্যারিংসে দেখা যায়। কখন এটা হবে? during any kind of deglutition, while we are eating any food, there will be one elevation on the posterior wall of the pharynx. Okay, এটাকে বলছে প্যাসাভেন রিজ। now what is the definition of passabile ridge? It's a fibers of palatopharyngeus. Own muscle part palatopharyngeus. Okay, it sweeps horizontally backwards to join the upper fiber of superior constituent. So this passabile ridge is formed by two muscles. একটা কি না palatopharyngeus আর একটা হচ্ছে superior constituent. Okay, and it produces U-shaped muscle loop at the posterior pharyngeal wall. Just now we have seen. Okay, দুটো মাসল মনে রাখবে, প্যারাটোফ্যারিঞ্জিয়াস আর সুপিরিয়র কনস্টিটিউশন। নাও নাসোফ্যারিংস এ চলে আসছে। নাসোফ্যারিংস কি আছে? রুট বডি অফ দি স্ফেনয়েড, দিস ইজ দ্য বডি। সো which one is the body of the sphenoid here? ঠিক আছে, body of the sphenoid, this is the olfactory bulb. Okay, and basi-occiput, this is the basi-occiput, and floored by the soft palate. So which one is the soft palate? Here, this is the soft palate. Okay, and the pharyngeal isthmus, that is the common between the nasopharynx and oropharynx. Okay, anterior wall কি হবে? by the posterior nasal aperture, যেটা আমরা সামনে দিকে দেখতে পাচ্ছি সেটা anterior nasal aperture, ওটা পিছনে গিয়ে আবার দুটো, there will be two entry, so that would be posterior nasal aperture, which would be separated by the nasal septum. Okay, and posterior wall is continuous sloping surface with a root posteriorly bounded by the C1 vertebra. তাহলে কোন vertebral লেভেলে থাকে? the C1 vertebra. Okay, okay, now which one is the pharyngeal tonsil? This is the junction of the roof and the posterior wall of the nasopharynx, connection of the lymphoid tissue. So what is the definition of tonsil? Aggregation of the lymphoid tissue. Any kind. Okay, appendix এ যেটা আমরা বলি, it is also aggregation of the lymphoid tissue. Okay, what is pouch of Lasker? It extends at the nasopharyngeal tonsil to the apex. Okay, nasopharyngeal tonsil যেখানে আছে সেখান থেকে যদি apex of nasopharynx যায়, you will get one pouch, that is known as pouch of Lasker. Then remnant of Rathke's pouch. Rathke's pouch কোন gland की derivative? Pituitary. Okay, Rathke pouch is a embryological remnant of pituitary gland. Okay, pituitary gland is developed from Rathke's pouch. So here we could see small dimple above the nasopharyngeal tonsil. স্যাজাইটাল সেকশনও দেখতে পাবো যে ফ্যারেঞ্জিয়াল টনসিলের উপরে ছোট স্মল দুটো ডিম্পল আছে, রাইট? সো দ্যাট ইজ দ্য রিমেনেন্ট অফ রাফ কেস পাউচ, ওকে? And craniopharyngioma may arise from there. It is one kind of tumor. Okay, name signifies it is coming from the cranial bones and the pharynx. So craniopharyngioma, it arises from the rough case pouch. Okay, so see, this is the nasal septum. Okay, so this is the rough case pouch anterior, and here you are having one bursa that is known as nasopharyngeal bursa. এটা কি আছে, এটা কিসের পিকচার? এটা সিটি স্ক্যান না এমআরআই? এটা এমআরআই, এটা এমআরআই। How you know this one is MRI? So MRI কেন করি? To know the soft tissues. Okay, তো এখানে তোমরা দেখতে পাচ্ছ টিস্যুগুলো পুরো ক্লিয়ারলি দেখা যাচ্ছে, ঠিক আছে? এখানে আরেকটা ফসা আছে যেটাকে বলছে ফসা ও ফ্রোজেন মুলার। ওকে, দ্যাট উইল বি জাস্ট বিলো দ্য pharyngeal bursa, ফসা ও ফ্রোজেন মুলার। তার মানে posterior wall of the pharynx, so many structures are there. Okay, okay, now what is Eustachian tube or pharyngotympanic tube? Okay, it is also known as sulfings. It is also known as sulfings. আর কোথায় sulfings পাই আমরা? অ্যাবডোমেনে পড়া হয়ে গেছে, বলো। হ্যাঁ, ভেরি গুড। এটাকে বলি ইউট্রাইন টিউবটাকে বলি sulfings. ওকে, তেমনি এই pharyngotympanic টিউবটাকেও আমরা বলবো sulfings. ওকে, another name. The orifice lies on the lateral wall of the inferior nasal concha, কত 1.25 cm behind. মানে inferior nasal concha থেকে 1.25 cm behind. Okay, and the upper posterior margin is the elevation of tuber tops. ঠিক আছে? তাহলে tuber tonsil কোথায় পাচ্ছি? pharyngeal tonsil কোথায় পাচ্ছি? at the superior border of the nasopharynx. tuber tonsilটা কোথায় পাচ্ছি? যেখানে পিটি ওপেনিং দুদিকে, just below there would be only posterior margin, there would be tuber tonsil. Okay, তাহলে tuber tonsil কেন নামটা এসেছে? because of pharyngotympanic tube. Okay, so this is the sagittal section. Okay, so which one is the pharyngotympanic tube? Open. ঠিক আছে, এখানে দেখ, এটা কি? এটা হচ্ছে superior meatus, এটা middle meatus, এটা inferior meatus. Okay, তো এখানে আমরা দেখতে পাচ্ছি opening of the pharyngotympanic tube. So you could see it is a connection between the nasopharynx to the tympanic cavity or the middle meatus. So this is the one thing you have to see, which one is known as the fossa of Rosenmuller. So where there is the opening of the PG tube, just back of that there is one elevation. Okay, এই এলিভেশনটাকে আমরা বলছি that this is the fossa of Rosenmuller. Okay, and which one is the retropharyngeal space? It is very much important. Retro মানে কি? posterior. So pharynx এর posterior wall এ আমরা দেখতে পাচ্ছি vertebra, right? In between that you are getting one space, small space. Okay, so this is known as retropharyngeal space. পিছনে vertebra, retropharyngeal space, then pharynx. আবার সামনে কি আছে? pharynx. Okay, so এখানে কি কি fold আছে? There are so many folds. Okay, প্রথমটার নাম কি? salpingopharyngeal fold, আরেকটা salpingopalatine fold. So name signifies salpingopharyngeal মানে পিটি টিউব আর pharynx এর মাঝে, ঠিক আছে? Then salpingopalatine মানে হচ্ছে পিটি টিউব and the palate এর মাঝে, দুটো fold লেখা যাবে, and also the pharyngeal recess and fossa of Rosenmuller. So আমি একবার pharyngeal recess টা লিখে দিচ্ছি, ঠিক আছে? So which one is the pharyngeal recess? This one is the pharyngeal recess. ঠিক আছে? It is all same. The fossa of Rosenmuller and pharyngeal recess and fossa of Rosenmuller is the same. Okay. Okay. Then, তোদের কারোর ইয়ে আছে নাকি? बारह बंडल तक ठीक है ना, बैक करके बैक करके okay. Oropharynx, what would be the demarcation of oropharynx? Anteriorly क्या है? To the soft parrot to the epiglottis. Okay, soft parrot to the epiglottis in between. Front में क्या होगा? Tongue and the oral cavity. Okay. So roof is formed by the soft parrot and the pharyngeal isthmus. Okay. Floor is formed by, that is posterior 1/3 of tongue, back of the tongue. Okay. And also junction between the tongue and the epiglottis. Okay. So these are the relation. Anterior वाले की থাকবে oropharyngeal isthmus. Okay. And posteriorly কোন vertebra? C2 C3. Nasopharynx এ কোন vertebra পেয়েছি? C1. Right. Lateral वाले की আছে? Pterygomandibular raphe, mandible, tongue and hyoid. Okay. Now laryngopharynx. So it lies behind the laryngeal inlet. ঠিক আছে, laryngeal inlet এর পিছনে থাকে, extend the upper border of the epiglottis to the lower border of the cricoid cartilage. Okay, so between the epiglottis to the cricoid cartilage, that is up to the C6. Anteriorly কি থাকবে? laryngeal inlet, posteriorly থাকবে pharyngoesophageal junction. Okay. Now about the constrictor muscle. কতগুলো constrictor আছে? Superior, middle and inferior. Okay, write it down the muscle. Okay, origin কোথা থেকে আসছে? Pterygoid hamulus. Pterygoid hamulus is a part of which bone? Pterygoid hamulus. Sphenoid. Okay, sphenoid এর দুটো পার্ট আছে না, pterygoid plate, সেখানে there would be one projection. Okay, that is known as pterygoid hamulus. Okay, then there would be pterygomandibular raphe, mylohyoid line of mandible and constrict the upper part. So this is the origin of the superior constrictor. This used to come as a short note. Okay, constrictor muscle of pharynx used to come as a short note. So there you have to definitely mention the origin, insertion, nerve supply and function. And preferably if you could draw some diagram also. Okay. So see, this is the superior constrictor. You could see so much large muscle, right? So from the pterygoid hamulus up to the mandible. This whole is extend the superior constrictor. So what is the peculiarity of this muscle? মাসেল গুলো কিরকম আমরা দেখি? লংগিচুডিনাল, রাইট? এখানে তোমরা কি লিখছিস? হরিজন্টাল। ওকে, দেন মিডল কনস্ট্রিক্টর কোনটা? এটা। ইনফিরিয়র কনস্ট্রিক্টর এটা, রাইট? So there are so many structure that is passing between the superior and middle constrictor, middle and the inferior constrictor. So this is the assignment for you. After vacation I will ask. Okay, structure passing through the constrictor. Which are the structure passing through the constrictor? Okay, so see there are so many space. You could see this space from here, some structure from the superior and middle, and from the middle and the okay. Okay, now the middle constrictor, greater horn of the hyoid. If you could remember the hyoid bone, okay. कौन से बॉर्डर से होता है मिडल कॉन्स्ट्रिक्टर? अर्जुन, मिडल कॉन्स्ट्रिक्टर हायोइডের কোন বর্ডারে হয়? হায়োইড পড়াশোনা করেছিলেন। এটাকে কি বলে? গ্রেটার কর্নু, তাই তো? গ্রেটার কর্নু মিডিয়াল বর্ডারে মিডল কনস্ট্রিক্টর, ল্যাটারাল বর্ডারে কি থাকবে? मुझे याद आ रहा है मायोसिस। ओके, medial border में रहेगा middle constrictor. So first one you are seeing greater horn of hyoid, lesser horn of hyoid, stylohyoid ligament and constricting middle part of the So this is the middle constrictor. Okay. Next is you should doubt why I am not saying about the insertion. Insertion is common. Okay. In constrictor insertion is common. Just you have to remember the origin. Origin is different. Okay. So next one we will see, that is the middle constrictor. So which one is the middle constrictor here? What is this muscle? Yeah, this is the mylohyoid. Okay, this is the, just now you have seen sternohyoid, right? What is this? This is the sternohyoid. This is the hylohyoid. Okay, what is this? डायगेस्टिक कौन सा बेली है? यार कैसे होगा? ये आएगा। Anterior belly of, this is posterior or anterior? Anterior belly. So posterior belly is this one. Okay, right? So what is this? This is sternocleidomastoid. So which is this? This is the middle constrictor. Okay. If you could remember the floor of the anterior triangle. Floor of the anterior triangle is made by hylohyoid and another muscle is middle constrictor. Okay, middle constrictor and the hylohyoid. So this is the hylohyoid of the middle constrictor. Okay. So now the inferior constrictor. So thyroid cartilage, cricoid cartilage, thyroid lamina constrict the lower part of the pharynx. Okay. So brachopharyngeal sphincter between the laryngopharynx and esophagus. This sphincter is very much important. Okay. Why? Because this inferior constrictor has got two parts. One is thyropharyngeus, another one is brachopharyngeus. So in between that one sphincter is there. So what is the importance? Suppose this sphincter fails, what will happen? Pharynx का काम क्या है? What is the function? Deglutition of food particle. So if the sphincter won't work, there will be lodgement of food particle posterior. Okay, it won't go further. Okay, so that is the function of the brachopharyngeal sphincter. Okay. So see, this is the pharynx. Okay. So this is the superior constrictor, middle constrictor, and here will be the inferior constrictor. Okay. What is the insertion? For three of them is median pharyngeal rapid. There would be common tendon. Okay, it is known as median pharyngeal rapid. Now stylopharyngeus. First muscle is stylopharyngeus. Okay, these are the which type of muscle? It would be the longitudinal muscle. Okay, so first muscle is stylopharyngeus. From the styloid process up to the कौन सा pharynx? Stylopharyngeus, हाँ? Middle constrictor में जाके insertion, right? So one part of the constrictor other with paratopharyngeus, okay? And the glossopharyngeal nerve. It is supplied by glossopharyngeal nerve. This is the sternum. Only muscle in the pharynx which is supplied by glossopharyngeal. Stylopharyngeus. So remaining is by there will be 5 muscles. Remaining 5. It's supplied by cranial axis. Okay, same thing. Sure. Palatopharyngeus. Palatopharyngeus. So palatine epididymis. What is the palatine epididymis? Between the hard palate and soft palate, there would be one epididymis that is known as palatine epididymis. Okay, and also it will be inserted in the lateral wall of the pharynx. So see, this is the stylopharyngeus. Okay, where it got inserted the superior constriction. Okay, and this is the palatopharyngeus. Okay, in the palate and the oral cavity, and this is the salpingopharyngeus. Just now I said salpinx, so that is extending from the PT tube up to the pharynx on the lateral wall. Okay, so these are the. Now next one is the salpingopharyngeus. So it is the inferior aspect of cartilaginous part of PT tube. This eustachian tube is partly cartilaginous, partly bony. Just like our ear cavity, partly cartilaginous, partly bony. Could you tell me which part is cartilaginous in our ear cavity? Which part is cartilaginous? Outer. Inner to definitely cartilaginous. কতটা? Yeah, she is right. It is up to the external ear. Okay, external ear is cartilaginous. Remaining is bony. Middle ear is bony. Okay, middle ear. Then embryonic membrane. Beside that, you have got 3 bones. Ear bones that will be bony, and posteriorly is fully bony. Okay, semicircular canal, and you have cochlea or bone. Okay, so it blends with the palatopharyngeus. Blends along with the palatopharyngeus. Okay, so if you have the cut section, so there will be 2 longitudinal muscles, stylopharyngeus and palatopharyngeus. Okay, and additionally there will be salpingopharyngeus. Sensory innervation. Okay, pterygopalatine ganglion, that is the maxillary division of trigeminal nerve. That is B2, maxillary division of trigeminal nerve. Oropharynx is by glossopharyngeal nerve, and laryngopharynx is by the internal laryngeal nerve. It would be same segmental nerve supply. Larynx के आगे जो है that is supplied by internal laryngeal. Then oropharynx would be by the glossopharynx, and nasopharynx is by the maxillary division of trigeminal. This is sensory supply. कौन सा सेंस आएगा sensory supply pharynx? nasopharynx चा olfaction असते. oropharynx से क्या असते? taste. Okay, just telling your reflex whatever, and the normal senses just like pain, pressure, task, temperature. Okay, this will come. And the laryngopharynx से क्या असते? same, the general sensation. Okay, general sensation. pressure, task. Okay. So this is the nerve supply. Okay, so this is by the maxillary nerve. You could see over here. Okay, यहाँ पर क्या होगा? Internal laryngeal nerve. Okay, so what is the arterial supply? See, ascending pharyngeal artery is a branch of external carotid artery. Okay, additionally कौन देगा? There will be ascending palatine, tonsillar, everyone. Okay, 3 branches of this, and facial artery also. Okay, motor innervation. This is very important thing, most common MCQ. Okay, all the muscle of pharynx is supplied by cranial root of accessory. Cranial root of accessory. Spinal root of accessory will supply which muscle? Just now we read. Neck की muscle है? Sternocleidomastoid trapezius muscle. That would be by the spinal root, and cranial root is supplying the pharynx, except the stylopharyngeus, which is supplied by the glossopharyngeus. This is the muscle. Now already a supply, this thing we have already discussed, right? Ascending pharyngeal, lingual, ascending palatine, tonsillar, and greater palatine. Okay, দুটো artery extra পেলাম, একটা হচ্ছে lingual artery, okay, another one is greater palatine. Okay, so they are forming one network. Okay, what is this? This is the tonsillar artery. Okay. Okay, now lymph nodes. What are the lymph nodes we could have? So it would be draining into the internal jugular vein. Okay, internal jugular vein. So it has got upper and the lower deep cervical. Remember deep cervical. Deep cervical lymph nodes. So these are all the deep cervical lymph nodes. It will drain where? The internal jugular vein. Okay, in this section I forgot one thing to show you the sympathetic chain. Okay, sympathetic chain will be found where? In the carotid sheath. What is the content of carotid sheath? Internal jugular vein, common carotid artery and its branches, then vagus nerve and sympathetic chain. Now the sympathetic chain of the cervical ganglion. Cervical ganglion কটা আছে? তিনটে আছে. Okay, write it down. Cervical ganglion superior করে C1 to C4. Superior cervical ganglion is C1 to C4. Okay, middle করবে কি? C5 to C6. Okay, and inferior কে করবে? Along with the T1 it will form stellate ganglion. It will form the stellate ganglion. Stellate ganglion. So there will be three cervical ganglions. Superior, middle, inferior. Inferior along with the T1. It will form stellate ganglion. Okay. So you will get this thing where just back of this internal jugular. Okay, sympathetic chain. Now what is the clinical anatomy? First one is Ehlers dehiscence. Ehlers dehiscence, most common questions. Okay, it's a potential gap between the two layer of fiber. I told inferior constrictor का दो layer है. Inferior constrictor का एक होगा cricopharyngeus and thyropharyngeus. Okay, so in between there will be one gap. Okay, that is known as Ehlers dehiscence. And which one is the hypopharyngeal diverticulum? From that there will be additional one potential pouch backwards. Retropharyngeal space you have seen, right? Retropharyngeal space. So from there will be one pouch. So in that pouch there will be lodgement of food particle. Why? Because this cricopharyngeus half is not working. Okay, between these two muscles. So see, this is the Ehlers dehiscence. So here it is forming one pouch or gap. Okay, this is the hypopharyngeus, this is the cricopharyngeus. So this is the Ehlers dehiscence. See, this is the pouch. Okay, which is coming outside. It is also known as Jenker diverticulum. Okay, just remember this one. This diverticulum is known as Jenker's diverticulum. At least if you read, maybe you could solve the MCQs. Okay, one time if you read, then also you could able to solve it. Okay, next one is pharyngeal tone. What is pharyngeal tone? You know all the muscle, so it has got its own tone. So if it is not maintained, what will happen? There will be disturbances during deglutition of food, right? So you know in physiology there will be neuromuscular incoordination. Like to एक जने तो टे लिखा है neuromuscular incoordination. क्या नाम है? लिखा है? थोड़ी सी महापात्र संबुलिंग एक ही जन में खूब भालो खूब भालो बोलो ना आजादे मी so cannot বলছি neuromuscular incoordination কোথায় হয় so ঠিক আছে so there will be dysphagia. Why? Because of sleep, alcohol, sedatives, hypothyroidism decrease the muscle growth. So these are the positive factors. Okay. Now infection of the pharyngeal space কি হতে পারে? There will be swelling swelling of the tonsil. Okay, and it would produce trimmus. What is trimmus? Trimmus मतलब क्या है? Trimmus मतलब there will be localized muscular movement. Okay, it is known as trimmus. Dysphagia, dyspnea, and the retrosternal pain. ठीक है, acidity में जो होता है retrosternal pain. So now the last topic is pyriform fossa. Last topic. Okay, pyriform fossa. Okay, just remember most commonest site for lodgement of foreign bodies. Okay, it could be fishbone, fins or coil. It's very common. Okay. So first we will see whether it is pyriform fossa or not. If it is not, then gone to the abdomen. Okay. So you have to see during removal of the internal laryngeal nerve, anesthesia to the supraglottic part. Okay. So it will produce lots of cough, bouts of cough. Okay. So this is the pyriform fossa. Okay. See, this is the pyriform fossa, both sides. Okay. Archi होते पारे, there will be malignant tumor of the laryngopharynx and commonest site for perforation of endoscope. Endoscope ফোকাতে ভুল করলেও কিন্তু ওখানে পারফোরেট করবে। বুঝছো? এন্ডোস্কোপের একটা লেন্থ থাকে, কত দূর থাকে জানিস? ফ্যারিংসের হচ্ছে 6, স্টমাকের কত? স্টমাকের কত? 25, তাই তো? এর রাইট স্ট্রিমের লেন্থ কত হবে? আমাকে স্টমাক অবধি পৌঁছতে হবে। ফ্যারিংসের হচ্ছে 6 সেন্টিমিটার আর স্টমাকের হচ্ছে 25, তাহলে কত হচ্ছে? should be definitely it should be more than 32. ঠিক আছে, কারণ ইনসিশন টিপ থেকে তোকে ফ্যারিংস অবধি যেতে হবে। ফ্যারিংস অবধি যেতে হবে, তার মানে মিনিমাম 35 থাকবে, মিনিমাম 35 length of the right side. Okay, that's all for today's class. Happy Diwali.